atezolizumab versus standard of care chemotherapy, and then we'll talk about pembrolizumab versus standard of care chemotherapy and try to set the scene with the data that is there. So in terms of the INDIGO 210, which was a phase 2 trial, which looked at the PD-L1 expression and basically looked at on the immune cells, immune cell infiltration in the tumor cell. So there is some inherent differences when we look at combined positivity score used by pembrolizumab, by the Merck study as compared to the Roche data as well. So overall survival was 7.9 months with a IC23 median survival of 11.4 months. But what was very interesting was again the durability of response that Tanner was talking about as well, that there is the tail of the curve which is looking much more stronger and much more and I think that is what is really most exciting, that we're seeing more and more patients who are alive at 12 months, 18 months and 2 years down the line. And those are the patients who continue to respond quite well to ongoing treatment. So INDIGO 210 toxicities were very similar. There's nothing significant that sprung out of it in terms of grade 3-4 toxicity, very little grade 3-4 toxicity. Immune-mediated toxicity as well, where 1% or less than 1%, some pneumonitis and things. But again, key thing will be identifying those toxicities and treating those toxicities at the earliest possible time. This is a phase 3 trial that we published in Lancet recently, and this was a sort of a largest study of metastatic bladder cancer that has ever been done. 931 patients were recruited into that trial, and there were 129 centers globally that took part in that. One difference was that 77% of the patient population were recruited within Europe, and that was one of the reasons that perhaps there was more vinflunine used in this trial, with almost sort of 50% of the patients who got chemotherapy were randomized to vinflunine compared to the other 50% who were divided between docetaxel and paclitaxel. It was designed in a hierarchical testing where it was basically focused on immune cells. If they're PD-L1, 2, 3 positive, that was supposed to be the primary endpoint. That the hypothesis was that PD-L1 inhibitor, atezolizumab, will significantly impact on that patient group. But to recruit to those patients, 100 patients in PD-L1 negative and PD-L1 positive, they have to have 931 patients. So the total study was 931 patients that were recruited to that trial. 1360 was screened, 931 enrolled, and they were well balanced in that sense. Baseline characteristics were very similar with little differences between the two, so quite good standard randomization. Overall survival in terms of the primary endpoint, looking at PD-L1 positive patients, was 11.1 months versus 10.6 months. So what came out of that was actually that this is a good marker of prognosis, not a predictive biomarker. You cannot stratify and select patients on the basis of PD-L1, but basically it was coming out that it is a marker that can give a good prognostic indication, irrespective of you treat them with PD-L1 inhibitor or chemotherapy. So that was one of the strong messages that came out from that. But because it was a larger study, so what came out as well is that if you look at the intention to treat population, then it becomes statistically significant with 8.6 months versus 8 months in terms of atezolizumab versus chemotherapy. Treatment-related AEs, again, were very much safety-wise. Chemotherapy versus atezolizumab. Chemotherapy was much better, sort of in terms of toxicity. There was significant benefit with immune checkpoint inhibitors, well tolerated, quality of life improvement with immune checkpoint inhibitor atezolizumab was significantly seen compared to pembrolizumab, compared to the chemotherapy arm. So this showed that the primary endpoint was not met. So in terms of that, it was a negative study, but there were a lot of positives as well. As I said, it was the largest randomized trial, and improved survival was observed with atezolizumab compared with taxane. And in terms of intention to treat analysis as well, it showed statistically significant significance in that sense. Was the study negative? Yes, the primary endpoint was not met. It did not meet its primary endpoint of improved overall survival in patients with greater than 5% PD-L1 expression on tumor infiltrating immune cells. So methodologically, this was a negative study. But at the same time, there were lots of things that were there. The statistical design was challenging with stepwise hierarchical testing. Chemotherapy control arm exceeded protocol design assumptions, and PD-L1 expression did not behave as anticipated. So there were lots of these things which were there, but at the same time, the durability of responses were seen in a good percentage of that is what was the most exciting part of that sort of trial, because when you see these patients in your clinics, quite often they're not interested in you telling them what's the median survival with that drug. What they're more interested is that what is the chance that they will be alive in a year, 2 years, and 3 years down the line. And that is what the immune checkpoint inhibitors have sort of completely changed and transformed sort of outcomes in terms of the advanced metastatic bladder cancer, where things have not literally changed over the last 25, 30 years. So sample size was the positivity, consistency, and efficacy data in terms of the phase 2 and phase 3. No significant, in terms of safety as well, it was important that there were no safety issues as well. So there are a lot of positives within that negative trial that we need to be aware of. In terms of the updated analysis from KEYNOTE-045, which was again pembrolizumab versus chemotherapy, using pembrolizumab 200 milligram versus standard of care chemotherapy, so very similar design compared to the InVigor 211 data. And again, what that study showed, looking at the assessment, which was used using a different method of combination of the positive scores, combining them together was basically used, expression using combined positive score with PD-L1 staining cells, tumor cells, lymphocytes, macrophages. And again, within that group, again, it was with pembrolizumab versus chemotherapy. Overall, very well balanced in terms of all the characteristics. There are a couple of differences. For example, liver metastasis was 1 in 3 in pembrolizumab, 1 in 3 chemotherapy. But if you look at the arm which did extremely well in the with the atezolizumab trial, if we go to 1.1, was the vinflunine arm. And vinflunine arm was significantly had almost 1 in 2 patients with liver metastasis and 1 in 3 patients who were performance status 2. So there were certain imbalances within the chemotherapy groups. And within the trial, the patients had chemotherapy, so 90 patients had vinflunine, almost 90 had docetaxel and 90 paclitaxel, but vinflunine arm had certain negative prognostic markers, which was a little bit more enriched with that. Overall survival was significant, median survival 10.3 months versus 7.4 months, so there was significant survival benefit, which was with a hazard ratio of 0.70. Again, important landmark in terms of moving forward, in terms of the providing new drugs and novel drugs to our patients with metastatic bladder cancer as well. In terms of the efficacy, PD-L1 again perhaps may well help to select some, but it is still early days. A lot of work is going on in terms of the biomarker world. Toxicity-wise, it was very similar. In terms of pembrolizumab, was much better tolerated compared to chemotherapy. In terms of grade 3 to 4 toxicity, there was very little grade 3 to 4 toxicity with the IOs compared to what you see with chemotherapy treatment. Areas of interest, again, we can see that with pembrolizumab, in terms of the grade 3-4 toxicities, there were very few grade 3-4 toxicities. All the pneumonitis and things we need to be carefully looking at as we are getting more and more of these drugs available to our patients in academic centers, but more important, recently, it is happening in DGS, district general hospitals as well, and we need to be carefully looking at these toxicities. So generally well tolerated. So survival benefit was maintained with longer follow-up, 10.3 months versus 7.4 months, and continued overall response rate with pembrolizumab was seen as well with chemotherapy. There is a recent EMA announcement that was based on the the first-line trials that both Merck and Roche are doing, and I think it will be useful for us to be aware of that more recently EMA has advised not to recruit on single-arm pembrolizumab in the Merck study or single-arm atezolizumab study in the Roche trial because IDMC, and again, we are not privy to the data what they have seen, but they are allowing the recruitment into chemotherapy plus IO versus chemotherapy, but do not allow randomization into IO alone arm. And again, they have very clearly mentioned that there is no safety issues. So patients who are on single agent IO and are benefiting, they can continue. So there's no safety issue, but there has been something that has been seen by IDMC for both Merck and Roche trials, and they are not randomizing in the single-arm IO. In terms of the third-line trial, there were second-line and third-line trials done. This is a trial that we published again recently in Lancet, a very multinational sort of a collaboration. Daniel Petrolak was the first author, and what it showed was that docetaxel plus ramucirumab versus docetaxel was doubling the progression-free survival. And the reason I put that is that this is exciting, that 6, 7, 8 years ago, we were really not talking too much about second line. And this trial was literally done in more in third line setting, and that's what really gives a lot of excitement to a lot of bladder oncologists nowadays. And again, as I said, progression-free survival in terms of was almost double. There is going to be a presentation at ESMO in October around this study as well. In terms of ongoing first-line trials, I mentioned there's a number of trials that are going on looking at PD-L1 inhibitor in combination with chemotherapy. As I said, this is a trial with the Genentech and Merck study where the single-arm chemotherapy is allowed versus chemotherapy plus immune checkpoint inhibitor, but single-arm immune checkpoint inhibitor in first-line setting is not recommended. And again, many of you will be aware of, and many of you would have taken part in the Danube study, which was the first-line AstraZeneca study. So that trial will be reporting very soon, which was looking at chemotherapy versus durvalumab plus tremelimumab. But again, what we have seen as clinicians is that we do see quite a number of patients who do progress quite quickly, irrespective of they are in the chemotherapy arm or immune checkpoint inhibitor arm. And that's where perhaps the biomarkers will hopefully help us in the coming years to try and get a better feel for how we can stratify and select patients on those. Because we are seeing a good number of patients who are falling off the curves, irrespective of they are on the chemotherapy arm or they are on the IO arm. And I think in the first line setting, where the median survival is 15 months, one feels a bit nervous of using IO without using platinum-based chemotherapy, and if the patient basically progress that quickly and are not able to have second-line treatment. So those are sort of key considerations that as a GU colleague we have to be carefully aware of and looking forward towards answering those questions. I would just put one case that we treated a few years ago now, and the reason I'm so excited about, there are a number